Hello, Dr. Olivia Hum. I can't even talk anymore. Dr. Olivia Hum. We are live, and today we are talking about rheumatoid arthritis and a bit of other bits of arthritis as well thrown in, because you've been working with the, I always want to put royal in front of this, I don't know why, but you've been working with the National Rheumatoid Arthritis Society to develop a really good booklet aimed mostly at women who have rheumatoid arthritis going into menopause. But I'm going to flip the narrative around a little bit on that. But before I get to that, just so everybody knows who you are, you're you're an advanced menopause care trainer and certified registered practitioner on the Medical Advisory Council of the British Menopause Society. You work with the very lovely Zoe Scheidel at Myla Health, and we've done lovely things with her on sleep, and we need to do more. You've also worked in Australia, thank you very much, and in East Timor, which really amazed me. I'm very impressed with that. If people don't know where East Timor is, it used to be a Portuguese colony, sort of a little bit to the north of Australia, sort of up there. It's a very, very small, but apparently a very beautiful area. And you've been working on this. So just so people know what we're talking about here, there are various different types of arthritis. Briefly tell us what the main ones are and how they differ.
So essentially, arthritis is divided into mainly two types. So there's inflammatory arthritis and then there's osteoarthritis. And so when people think about arthritis, they think, oh, you know, my granny had a hip replacement, or, you know, my knee hurts after I had a football injury. That's osteoarthritis. So that's what we get often as you get older. That is wear and tear on the joint. So the joints gradually break down with time. And it's a sort of natural process of aging. For some people, it happens quicker than others. And osteoarthritis, we also often see starting to present in women of menopausal age. So often it's your hands. So women will often notice in their 50s, their hands start getting stiff. And that is much, much more common. And people often get this mixed up. Yeah, exactly. People often get this mixed up with rheumatoid arthritis. So rheumatoid arthritis is a type of inflammatory arthritis. And what inflammatory means is that essentially it's an autoimmune condition. So autoimmune means that your body gets confused. It starts attacking your own joints. And when it does that, it causes inflammation. So what we see in rheumatoid arthritis, or in the other types of inflammatory arthritis, are big, hot, red, swollen joints. But there are also, it affects the whole body. So it's not just about one joint being painful. It's a condition which affects the whole of your body, but especially your joints.
God, that must be incredibly awful to live with. The pain must be absolutely horrendous. When it comes to the symptoms, how much, because, you know, I mean, you would see every day in your menopause clinic women coming in and saying, my joints are aching, my hands are aching, my muscles are aching, everything over my entire body is aching. How much overlap is there between rheumatoid arthritis and menopause symptoms, and how do you tell them apart?
It's really hard. And that's part of the reason why NRAS, which if anyone is watching this who does have rheumatoid arthritis, I'm really hoping you go on their website. It is superb. But a few years ago, they started running a survey, because one thing about rheumatoid arthritis is it often presents in women in between 40 and 60, which obviously, as we know, is the prime age where women start getting symptoms of menopause. And they realized, they sort of asked their members, and they realized that many of their members found that their symptoms had worsened over menopause, the menopausal transition, but also that it was very difficult to tell them apart, because exactly as you said, joint pain for many women is a symptom of menopause. But the other symptoms which come with having a chronic inflammatory condition are things like fatigue and brain fog and poor sleep and anxiety, and all those things we know are also more common in women with inflammatory arthritis. So it's often very different to tell what's what, but also what's really difficult is that many of these women are being seen in a specialist rheumatology clinic where they are on very complex medications that as a GP we often don't know very much about. So they really just get sort of pinged from one department to another with the rheumatology rheumatologists saying, I don't know anything about menopause, and the GPs saying, I don't know anything about rheumatoid arthritis. And these poor women really felt that they were just stuck in the middle. So no one was taking responsibility for their care. And they felt really sort of abandoned. And that is why NRAS went to try and sort of do this booklet, which is on their website. It's really good. And it goes through sort of every single bit of what you need to know about menopause and rheumatoid arthritis.
You mentioned there that it often appears in that period where perimenopause symptoms start. What do we know about the role of estrogen then in rheumatoid arthritis and its progression?
So it's really confusing, and actually it's one of those areas in which a lot of research is being done. So what we do know about rheumatoid arthritis is that in times like pregnancy of high estrogen, often women will find that their rheumatoid arthritis goes into remission, that it gets a lot better. And we know that for a lot of women, after menopause, their rheumatoid arthritis gets worse. So we know that estrogen has an anti-inflammatory effect. And some women do find that when their estrogen level drops, this worsens their rheumatoid arthritis. So there's lots of other different data. So one study shows that if you go into an early menopause, you are more likely to develop rheumatoid arthritis. And there is also this relationship between POI, so premature ovarian insufficiency. There is a relationship between rheumatoid arthritis. So for some women, POI is also an autoimmune condition, we think. So if you have one autoimmune condition, so if you have one condition in which your immune system attacks your body, you are more likely to get others. So we often see them. So you might have POI, and then you are likely in the next few years, you may have more likelihood of developing another one. So we check your thyroid bodies, we check the antibodies against your adrenal glands. But one of the things you know, if you have POI, you are more likely to develop rheumatoid arthritis. And the other way around, if you have rheumatoid arthritis, you are also more likely to develop POI. And we don't know why. It might be because of the chronic inflammation affecting your ovaries, or it might be because it's the same mechanism. Your body sort of triggers immune responses to your own body. So that may be it. But again, it's a really interesting and very complicated area of research.
Yeah, absolutely, it is, and we certainly need more research on everything. But this is one that really does, especially with an aging population. Not to mention just the the POI ones, and I think they're finding that POI now is more common than they thought before. I mean, used to be, say, around. Sorry, I've got a hair in my eye. Used to be around about 1% or so. I think they're saying it's now between 3 and 5% of the population, and even that might be an underestimate. It's
absolutely. I think people just didn't used to come in with it before. So when I look back over my sort of years as a GP before we used to know anything about it. So for a lot of women, they get to sort of 37, 38 and think, oh, brilliant, my periods have stopped. But we now know that POI actually has, unless it is treated with estrogen, has really long-term impacts on the heart and the bones and the brain. So it is really important that we see these women and they're treated adequately.
Yeah, absolutely. Which then brings me to the question is, so if I'm on HRT or taking estrogen, menopause hormone therapy, as the rest of the world calls it, does that help? Does it alleviate the symptoms? Does it slow the progression? What do we know about that?
So again, it's a sort of area of research. So currently, and then it's the two things that you mentioned. There are two separate things. Does it help with the symptoms of rheumatoid arthritis? And a lot of women find that yes, it does, because it helps with those crossover symptoms. So we know that often being on HRT for some women can help them sleep. We know it can help with the way that pain messages are modulated to the brain. We know it can make you less anxious. And we know that for some women, HRT will help with this sensation of brain fog. So that can improve. Whether it alters the progression of the disease is a different thing. And that at the moment, the jury's out. So we don't know. And there are studies showing that it does, and there are studies showing that it doesn't. So again, if you listen to the sort of specialist rheumatologists and immunologists talk about this, they'll say we can't conclude anything at the moment about that.
Yeah, because it was especially, I mean, a lot of people say, well, my joint pain went when I started HRT. And they'll think that maybe it's that it's helped their osteoarthritis or it's helped their rheumatoid arthritis if they have it. But basically what you're saying is we just don't have enough evidence either way.
We don't know. And we know that estrogen is anti-inflammatory, but inflammation is actually really complicated. It involves a lot of different chemicals and a lot of different systems. And so it may affect one aspect of the inflammatory pathway, but not another. So We just don't know. However, a lot of women anecdotally report that they do feel better on HRT when they have rheumatoid arthritis, but that may be because it helps with all these other symptoms rather than it's actually altering the disease. But again, I suspect this is the kind of area that we may well in 5 years' time be able to say things that are a lot more definite.
Yeah. And you mentioned before that the RA medications are quite complicated and ones that, the GPs don't know all that much about, and the rheumatologists don't know all that much about menopause. But from what we know, does HRT play nicely with those medications?
Yeah, so as far as we know, there isn't. They are completely different in the way that they work. So the way that most of the rheumatoid arthritis medications work is by trying to suppress your immune system. So it stops your immune system from going rogue and attacking your own joints, and that's the way that it works. And estrogen HRT works on a completely different pathway. So for the majority of women with rheumatoid arthritis, they can have HRT. However, one thing we do know with women with rheumatoid arthritis is that they have an increased thrombosis risk. And again, this is probably due to the chronic inflammation. So what we would be looking at is giving them the type of HRT, which we know it reduces the risk, which doesn't give them this increased risk. So that means taking estrogen via the skin rather than orally. We know that oral estrogen does slightly increase your risk of clotting, of blood clots. That isn't really an issue for most people, but if you already have a high underlying risk of thrombosis, say with rheumatoid arthritis, you need to be taking estrogen via the skin rather than orally, ideally.
Ideally, yes, that makes sense. The other things that it can affect, actually, before I get to the other things that affect, what about testosterone? Because that's the other thing that people say these days has it's changed my life, it's stopped my joint pain, it's given me back everything in my life. What do we know about it? Is there any evidence for testosterone?
So no data. So little tiny trials on testosterone and joint pain and testosterone and bone density, but again, they're all inconclusive. They're just really small trials, and so we can't say anything definitive about the effect of testosterone on joint pain or on rheumatoid arthritis, unfortunately.
Yeah, gosh, we have such a long way to go on these. The other things that we probably don't think about with rheumatoid arthritis was we say, well, we've got the joint pains and whatever, but it has a significant effect on other parts of your body as well, cardiovascular disease and bone. So what's going on with those?
So we know that with the cardiovascular disease, part of the issue, again, is chronic inflammation. So inflammation in the walls of the arteries, we know can increase the risk of you forming plaques. Plaques are the build-up on the wall of the arteries, and these can break off and become lodged in your coronary arteries or in the arteries leading to your brain, and that's heart attacks and strokes. So we know that women with rheumatoid arthritis have a higher risk of heart disease. And then we also know that women with rheumatoid arthritis have a higher risk of osteoporosis. So it's one of the risk factors for osteoporosis that we look at. And again, we know that after menopause, when your estrogen level drops, that also increases your risk of osteoporosis. So again, these are women who are at high risk, and someone needs to be looking after their bones. And a lot of rheumatology departments are very good at doing that. Some rheumatology departments are less good, and definitely it is something that has not been done well in the past. But I think one of so osteoporosis is something I'm really interested in. One of the really great things that have come out of this real emphasis on women's health has been a sudden real increase in interest about osteoporosis. So for women with rheumatoid arthritis, looking after their heart and their bones is really, really important.
Yeah, absolutely. I hope these messages are getting across, especially the heart and the bones on those sorts of things, because really it is, even in that, I did a fantastic interview, plug here for Mike McClung from the States, who was saying, we've got to be starting to address this way earlier than we are now. Waiting till women are 65, the horse has bolted. We should be having these DEXA scans much earlier on in that sort of 3 to 4 year window before and after menopause. We really need to know who's coming into menopause with a low score already, because at 65 they're the ones who are going to have the osteoporosis. So we've got to be thinking about bones much earlier in life, much earlier.
Yeah, I absolutely agree. And I'm hoping to be I think the Royal Osteoporosis Society are really trying to do some work in this area. So what we know is that national guidance about osteoporosis in the UK sort of says we should be doing this targeted case finding, but that's in the guidance, but that's never been communicated to GPs. And it's definitely something that you don't have time to do in your 10-minute appointment in which you're trying to cover 4 other different things. You suddenly go, wait a minute, you look like you're at high risk for osteoporosis. Let's give you a DEXA scan. I'm in an area where actually we have no osteoporosis clinic, but we have excellent access to DEXA scans. And we have other areas where people are waiting a year or 2 for a DEXA scan. I mean, it is the variation throughout the UK is absolutely huge, but I completely agree with that. I think we need to be identifying women who are at high risk. And I would say if you are someone watching this and you're not sure if you're at high risk, if you have a look on the Royal Osteoporosis Society website, they have a risk checker. So you can go through and you can put in all these things and work out whether you're at high risk or not. And if you are at high risk, then do ask your GP for a DEXA scan, because actually in many areas you will be entitled to one. And it's forewarned is forearmed. Like if you know early, you can start doing the weight bearing exercise, you can start increasing your calcium intake, you can take vitamin D, and you can monitor it through time. So it is really, really worth getting that sorted. And unfortunately, it's not going to come to you nowadays. You have to do it yourself, because we don't screen in the UK for osteoporosis.
Yeah. And interestingly, then I'm just trying to think of what's on that list of risk factors, and I don't think rheumatoid arthritis is.
So it's not. And actually what you're supposed to do is there is a little fix for the FRAX score that if they've got it, you're supposed to tick the diabetes box instead or something like that. There's some kind of thing underneath it. But it's like, but again, it should be. And as they update FRAX more and more, it should come into it. But it is acknowledged. And interestingly, there are quite a lot of conditions which we think are associated with osteoporosis. And it's probably for them because there are conditions, for instance, like inflammatory bowel disease, in which people have to take a lot of steroids. But with rheumatoid arthritis, we think there is something independent about the process which also increases your risk. So it's not just the medication, it is also something to do with the inflammatory process that increases your risk of osteoporosis. So it's very important that you need to look after your bones.
Yeah, absolutely. So bones and heart. Are there any other effects of it that people need to take into account?
Well, there's the joint damage. So the problem is with this inflammatory process in the joints is that it eventually damages them. And so the real key is that the treatment needs to be started as soon as possible. And if you're someone who's thinking, wait a minute, my joints really hurt with menopause, how do I know whether this is joint pain due to menopause or osteoarthritis or rheumatoid arthritis? The key things about rheumatoid arthritis are the joints are red and swollen and hot. It often starts in the small joints of your hands, especially these ones here. And they are really tender. You touch them and squeeze them and people wince. They really hurt. It can affect other joints. It's often symmetrical, so it'll be the same joint on each side, but not always. And what you'll find is that it will affect one joint for a bit. Then so people come in and go, oh, I had it in my hands, really sore. Then they went away. Then my elbow randomly swelled up, and that was really odd. And then suddenly my feet are really painful. But often you can see the signs. Because it's an inflammatory process, you often feel a bit like you do when you're going down with a cold, that sort of horrid, achy, sore throat, slight temperature sort of feeling, because that's inflammation. But when you've got a cold, the inflammation lasts for a few days and then goes again. But with something like an inflammatory condition like rheumatoid arthritis, it lasts for a long time. So often you feel quite unwell with this. And the other real thing that differentiates rheumatoid arthritis from joint pain is morning stiffness. So often people will, and again, I'm 51, often we feel a bit stiff in the mornings, but this is extreme morning stiffness. So we're talking about 30 minutes in the morning of your joints feeling really stiff, not being able to pick up your cup of tea. Really, you move them around, but they don't get any better. So it's prolonged sort of morning stiffness, swollen, hot, red, swollen joints, feeling unwell. That might indicate that this is something more than just a little bit of aging. So that is when to see the GP, they can order some blood tests. And if they do think you have an inflammatory arthritis, in an ideal world, you should be seen very quickly by the rheumatology department. So their aim is to see you within a few weeks.
It must have, it must have an incredible effect on your mental health as well, because that must be incredibly frustrating to not be able to do what you could do as a routine thing, let alone, how do you hold a pen when you go to work? It must really impact on people's mental health.
It really does. And we know, again, from data that there is a higher incidence of anxiety and depression in women with rheumatoid arthritis than in the normal population. And if you think about it, and that's due to all sorts of different things. So the impact, you're talking about sleep, so the impact on sleep, the impact on day-to-day life, because as we know, any of us who work in the menopause space, we're dealing with women in their 40s and 50s. And it is a time when things are really busy. So not only do you have quite young children often, but, you know, women are working, they are trying to manage a household, their parents are beginning to become more dependent. You've got this perfect storm of everything going on. Then suddenly you find you can't do up buttons, you know, you're feeling really tired and brain foggy all the time, but you're trying to cope at work. You know, there's all these different things going on. So it's not really surprising that people do feel that their mental health is impacted by it.
Yeah, absolutely. Which leads us very nicely into what helps. So we know that people can feel a bit better with the HRT, but that may not necessarily be for everyone, or may not necessarily be even that effective, because we just don't know. So are there things that people can do then if they're facing this that is going to help? You know, diet, exercise, because this is the other thing. Let's start with exercise, because I mean, the first thing is when people go, oh my God, everything hurts. They don't want to move. Is that the absolute opposite of what they should be doing? Does exercise help?
Yeah, absolutely. Exercise does help. So, and again, I would really signpost everyone to the NRAS website where they've got so much information about this. So you're absolutely right. The normal kind of rational result of having painful joints is that you don't want to move them. But actually, we do know that mild exercise helps, and especially exercise that doesn't put lots of impact through your joints. So things like swimming or walking or, you know, Pilates or anything that is just sort of gently stretches but doesn't put enormous impact. Although some people do. And again, what we would say in an ideal world is that you would have a physio who would be able to give you really proper rheumatoid arthritis focused advice. Given that that probably isn't going to be available, there is a huge, there's a program called Smile that NRAS run. That's a sort of online program that gives you loads of information about what to do. Again, it's not all the time. So information will come and go with rheumatoid arthritis. So sometimes your joints will feel relatively normal, and other times they'll be really painful. But we know, and we've got data on this, that keeping them moving does really help with the pain.
Yeah, that'd be such an important thing. You mentioned diet, or you mentioned calcium there, making sure you've got enough calcium in the diet. Is there, if you've got, is it worth taking a supplement if you've got not enough in your diet? Or, and are they, because we know we say most people these days shouldn't necessarily take a calcium supplement because of the artery risk associated with that, but are people with rheumatoid arthritis an exception to that rule?
As far as I know, we would give them the same advice that we would give everyone else, which is to try and get your calcium through your diet if you can. And again, the Royal Osteoporosis Society calcium calculator is very good for this. Just go through and have a look at what you eat. There are some really good quick wins on there, like weird, like things like dried apricots have got loads of calcium in. You know, there's all sorts of weird things on there that you can try. Vitamin D, probably everyone in the UK should be taking vitamin D. And again, there is some evidence about vitamin D and arthritis, but sort of they've looked into. So it's definitely worth taking just a normal dose vitamin D supplement. Interestingly, there's a lot of interest online about this thing called an anti-inflammatory diet. But so there is some data about the Mediterranean diet and inflammation. So again, I looked into that thinking, surely this is just one of those internet things, but actually it's true. So we know the Mediterranean diet is beneficial for your cardiovascular system, but there is also some benefit in rheumatoid arthritis. And this is a diet which, as we know, essentially is huge number of fruits and vegetables, so at least sort of 5 or 6 a day of non-starchy vegetables, different fruits, lots of different colors, whole grains, seeds, protein from things like fish and lean meat, low in saturated fat, low in processed food, high in olive oil. This is all much easier if you live on a Greek island, clearly, which is why we call it a Mediterranean diet. But all of those things we know can have some benefit. In terms of supplements, interestingly, there is quite a lot of data.
Just before you get to the supplements, just let me take you back there to the internet and anti-inflammatory diets. The other end of that is the Mediterranean diet is one thing, but then we have this whole industry of anti-inflammatory diets, which are basically, sugar is going to kill you. If you eat fruit, it's going to kill you because it's got fructose. when people are looking for an anti-inflammatory diet, should they bear that in mind, that those ones that are really extreme may not necessarily be the ones that they should be looking at?
Yeah, absolutely. So when we talk about an anti-inflammatory diet, we mean the Mediterranean diet, which is a very broad diet which allows you to eat lots of different things and does not cut out any kind of food group apart from the, trying to eat less processed food. We would really advise not the, as you said, not the extreme diets often end up, firstly, they have lots of things that they say that just aren't true or are based on one like teeny little study or what someone thinks they should be. But actually, we need to go with data and evidence. And the Mediterranean diet is what we would call medically an anti-inflammatory diet. And that is just a broad range of eating different things. But the key thing is fruit and vegetables. So fruit and vegetables, lean meat, lean fish, whole grain. And that it's as simple as that. There is absolutely no need to do anything else.
It's actually quite simple, really, isn't it?
It is quite simple. It's made very complicated by the internet.
It is.
But actually, and that's the data. Yeah, exactly.
Yeah, God, I mean, it scares me every time I open my social media feed. It just has become so unbelievably overcomplicated, and you just look at it and you think, where did you get that from? Anyway, there you go. So diet, exercise, and you were starting on supplements there. Are there any supplements that can make a difference? Because we know with menopause itself, there's very little evidence for the vast majority of things that are out there. What about when it comes to arthritis, osteoarthritis as well? Are there any supplements that can help with that?
So again, I'd say this is also the Wild West, isn't it, in terms of, these completely unregulated industry. And it's so, and I think also it's just so natural, but when you're feeling so rubbish to just think, oh my God, maybe if I just take this will be the thing. The only evidence, interestingly, that we have is for the omega-3 fish oils. There has been some data, and there's a good review article about that, which is freely available, actually. So if you just type in rheumatoid arthritis, omega-3 or fish oils, and on the, I think it's the Arthritis UK website, they've got a really good summary of all the data. And so what they have concluded is there is possibly some benefit in having oily fish for reducing joint pain and inflammation. And that is literally as far as they go in terms of their conclusions. Whether it has to be oily fish or supplements, we don't know. And it may well be just as good to have 2 portions of oily fish a week, which is what we recommend anyway. But that is the only evidence and the only supplement I could find that had any evidence behind it. So all the rest, again, anecdotal data or teeny weeny trials. So if you do a trial in which you give 10 people your supplement and ask them if it works, there's going to be an enormous placebo effect. That's not a trial. So it just, buyer beware, essentially.
Yeah, absolutely. Yes, testing amongst your own pool is always to be avoided, really. The other thing I guess out of that is that if NSAIDs, those kinds of things, do they make any difference? Are we living on ibuprofen? What are sort of are there practical things that you can do at home if you're having a flare up as well that really sort of helps to relieve your discomfort?
So again, we would hope that people with flare-ups, so if you have this, that you would be under a rheumatology team. And so there are a lot of things that they can do for flare-ups, including giving you steroids, which can sometimes, what steroids do is they suppress the immune system. And sometimes we can give them as an injection, and sometimes we give them orally, and they stop your immune system from attacking your joints, and that can really help. We really want to try and avoid people having flare-ups as much as possible. And that's what the immune sort of system medication that suppresses the immune system is about. People do take anti-inflammatories to try and reduce the inflammation in the joints. They can be quite effective. As we all know, anti-inflammatories taken long-term are not great, unfortunately. They can damage your kidneys, they damage your stomach. They don't make people feel great. So again, hopefully, and again, what many hospitals will have a sort of rheumatology advice helpline with the rheumatology nurses who will be able to manage flares with you in terms of helping with medication.
Yeah. All right. Take home messages for people in menopause with rheumatoid arthritis. Then, what are your main points for them?
I would say go on to NRAS. NRAS have also started a sort of online support group for people who are struggling with joint double whammy of menopause and rheumatoid arthritis, find out the information, really look at all of the things that they do, the lifestyle factors that can really help. And also just one of the really big issues with rheumatoid arthritis is fatigue. And what we see all the time is these women who are just managing so much, but also just exhausted. And so I'd really say, as I say to women all the time, and I'm sure you do, just look after yourselves, ask for help if you can. Don't take on too much, allow yourself to rest. It's tough managing both those things at the same time, but often people are caring for others but not looking after themselves.
Yeah, it's a very, very tricky time with two very, very tricky things, really, isn't it? And so people can find this booklet on the National Rheumatoid Arthritis Society website and download it for free, which is nice,
Yes.
which is another good thing, because this is one of my big bugbears at the moment, is making sure that people actually get access to information for free, because I'm sick to death of everything being behind a paywall, because it just means that loud voices on social media get heard more than evidence-based information. So I'm very glad that you've done this, and I'm very glad that it's free, and I'm very glad that it's easy to find. Is it also on the BMS website, or they've just linked through to it on the arthritis site?
I'm not actually sure. So it was developed in conjunction with the BMS, and we sort of co-signed it, but I don't know if it's actually freely available on our website. I think it has to be downloaded on the NRAS website. So I will have a look at our website and see if we link through to it.
Yeah, brilliant. Oh, well done. And if people want to find you, where do they find you again?
So Myla Health, MYLA Health. That's with me and Zoe Shadell. That's our private company, but also I work in the NHS and via the BMS as well.
Wonderful. Thank you so very much for that, because it really isn't something that we talk enough about, and it really is. In fact, we just don't. You just never do you? You just don't. We have all of these things, we put them in silos, and we never join the dots on them. And whereas, we are living crossed over and integrated beings, where everything turns into a bit of a mess on the inside, really. So it is good to cover those things that are not spoken about enough. But the other thing I forgot to ask actually was, what's the incidence of it? I actually should have looked this up myself, but I didn't. What is the incidence of rheumatoid arthritis?
That's the kind of number that I didn't know, that has just gone completely out of my head. But it's much more common than you'd think. So what I read was 1 in 100. But I thought, again, as a GP, that does sound like an awful lot to me. I don't know if I can think of one of my 100 of my patients with inflammatory arthritis, but that's definitely what it says. But again, I'm not quite sure what the denominator of that is. 1 in 100 women, and 1 in 100 women with, in between 40 and 60. It sounds like quite a lot to me, but that is the figure that I found online.
Yeah. And it's interesting because we often associate it with, we think, really old people have this, once we got to the point where we're seeing the sort of fingers all sort of, bent over. We don't really think of it all that much in younger women. I mean, I still think I'm a younger woman, so clearly I'm deluded. Apparently, I'm a geriatric. But I think of menopause and women around menopause as being younger women. But we just don't think of it in this sort of age group, really.
No, we don't. And that is quite isolating, isn't it? I think, for women who get it, because when you do, and again, as we said, 40 to 60 is the age often which it first presents. You feel I think they feel very alone, because you've got arthritis, which everyone associates with being an old person, but actually it's a chronic inflammatory condition which goes on for years. The great thing about it is that the new drugs that are around for it are absolutely superb, and so there's more and more new stuff being developed all the time. So for many people, this will be something that is a chronic condition that can be managed without causing, as what you're referring to, the damage that you see in the joints of older people who often just didn't have access to those medications. So we shouldn't be seeing that happening.
Oh, that's good to know, because we are an aging population, and my other big thing is, if we're going to live 30, 40, 50 years post-menopause, we need to be doing it in the best health that we possibly can be, because otherwise we can't look after ourselves or anybody else. So that is good to hear. Excellent. Thank you for that, because rheumatoid arthritis is something I know absolutely nothing about, as you may not have gathered from my questions, but it is such an important thing. So thank you very, very much for doing that, and thank you to the National Rheumatoid Arthritis Society for working with the BMS to do that, because it's an important thing. So I shall now let you go and get on with your day, and hopefully I'll speak to you again soon.
So thanks very much.